I'm Brian Davidson, one of the transplant surgeons here at the Royal Free. I'd like, first of all, to thank David, if he's not already left, for the Trust's support for this group of meetings. Now, this, as you'll probably see from my talk, is not a scientific meeting. The intention is not for us to go into the science of should we do X or should we do Y. The purpose of this meeting is to have public engagement and for the public and transplant patients, the carers, to feedback comments on a topic. And the topic we have today is the organ shortage, and one of the solutions for the organ shortage, which is the use of marginal grafts. Now, clearly, this whole topic comes about from the organ shortage. If we didn't have an organ shortage, we wouldn't be considering using marginal grafts, and therefore we are responding to things that are happening up and down the country from the point of view of organ donation. So, first of all, I struggle with this concept of how you can convey the concept of a marginal graft to somebody that knows nothing about liver transplantation. So you'll excuse me that I took an analogy down to Tesco's, because when I look for bananas, and I do go to Tesco's regularly, I do say, well, what is our marginal banana? And we have a bit of a preoccupation with voting and getting responses here. So anybody want to comment on what they would choose in their Tesco's choice of bananas? Because I think here that the optimal banana is number 6. Any comments? And the other ones I would say are marginal. And this is a very simplistic approach as to how we choose things and how we assess things. And visual appearances are important, and just as it might be important when you go to Tesco's, visual appearances are important when you assess an organ. Another analogy, an absolutely perfect Tesco's apple. You know by the appearances of that that is going to taste good, that it's going to be an ideal apple, and you could similarly analogize that to a perfect organ. Here's probably what we're talking about today, a rather withered, slightly suboptimal apple, which would be our marginal fruit. And here's the one that will come into pig fodder. And the big question is, well, what are these changes? How subtle are these changes? And can we detect them? And at what stage have we gone beyond something that is useful? From the point of view of the liver, again, appearances are actually quite important. And you can say just by looking at that first organ here, that this is probably a liver that could be transplanted in function. Might be a bit patchy, but it's the right colour, it's the right shape. It's not particularly rounded on its edges. Whereas you can compare that to this, which looks a similar shape, probably a bit bigger, and this is a severely fatty organ. And that liver in the centre there, I saw Paolo in the audience. I think certainly we would turn that down, and I suspect that they would in Birmingham as well. And then you go right through to the extreme of the damage that you might find in an organ on retrieval, and that's the kind of organ we end up transplanting, or transplanting a recipient for that organ. That's a cirrhotic liver there on the right. Unfortunately, in transplantation, you don't get these extremes usually. You'll usually get something that looks a bit between the satisfactory organ here and the severe steatosis. And judging changes due to fatty liver is perhaps the most difficult thing for an organ retrieving surgeon. So what we're going to talk about is suboptimal or marginal livers, and therefore we need to have some sort of comparator. So what is the perfect transplant organ? And I suppose this would be our description of what might be a perfect donor for liver transplantation. A young donor, less than 40 years, normal liver function, He's not fat, he's got a normal BMI, a brain-dead donor with no comorbidity. Unfortunately, if you actually look through our transplant practice, we virtually never see these donors. And if we do see these donors, because they're so rare to get a perfectly functioning liver, we will be asked to split that liver, and that liver will be used for 2 recipients. And as I'll show you shortly, the fact that we have to use that liver for 2 recipients will make that a marginal organ. Perhaps one of the biggest challenges we have right now is the effect of obesity on society. And although that's of perhaps major concern if you're looking at UK incidence of diabetes or heart disease, obesity does also affect the transplant community. This is the most recent data from the government that would suggest that 60% of adults in the UK are overweight, and a quarter, 1 in 4, have obesity with a BMI of over 30. And you might say, well, that's a big problem, but perhaps the biggest problem of all is that we're influencing our children as well, and that almost 1 in 3 children are significantly overweight in the UK. So not only have we got the problem, but we are actually producing a problem for the next generation. And not only is it going to be a problem for those individuals, but it's a huge problem for the transplant community. Now, why is that? Well, the reason for that is that if you have fat in your donor liver, this is one of the causes of a marginal graft. This recent study looked at biopsies taken of their livers that were coming into the transplant program, and 70% of all the livers that were coming and being used in that transplant program had significant fatty change in the liver. And you can correlate that fat within the liver with measures of outcome or aspects of the donor. For example, those fatty livers were associated with patients that were overweight, patients with a high BMI, and significantly they were more common in male donors. And the impact of the fat in those donors is very significant. Non-function of that liver after transplantation is significantly more common with a fatty donor. Renal failure after transplantation is more common, and perhaps even more importantly from the point of view of implications for patients and the cost to society, retransplantation is significantly more common if you have a fatty donor pool. So split liver transplantation, taking one liver, splitting it so it can be used for 2 recipients, allows 2 transplant procedures to be carried out, but there is a 50% overall increase in graft failure. One of the other topics we're going to address today is whether or not we can use perfectly good livers from people that have infections, and particularly viral infections. And as you know, some viral infections are extremely common. This is the global incidence of hepatitis C. And as you can see, some communities have between 1% and 5% of all the population infected by hepatitis C. Should we use these organ donors, and who should we use them for? That's going to be addressed later in the day. So what about other sources of grafts that may be considered marginal? It was mentioned earlier about abdominal grafting for the condition amyloidosis. As most people here will know, this is a genetic condition that involves deposition of abnormal proteins. It produces organ damage for the individuals affected, and it can be cured or partially reversed by organ transplantation. One of the additional benefits is that the organ that's used to transplant those individuals, their own liver, can then be given to another recipient and can function satisfactorily, although there is long-term issues in graft function or viability related to the genetic abnormality in that donor liver. And what about live donors as a significant source of organs? Are we pursuing this in the UK? Well, there was 30 live donor transplants in the last year, So it's fairly small potatoes in comparison to the other sources of donated organs. And the utilisation of live donors, where a portion of one, usually a relative, would be given to another individual, is actually decreasing in the UK. There was almost a 20% decrease over the last year. So again, it's relatively small related to liver transplantation, although quite an important factor if you look at the bigger picture of renal transplantation. So we can discuss perhaps some of the issues that are associated with a marginal graft, but when it comes down to the nitty-gritty, there's very many unanswered questions. For example, is there a test for a marginal liver? And the answer, I think, is no. Can we detect marginal livers? And I would say not always, but we can usually predict which ones have a risk. Should we use them? I think that the whole idea of this meeting is for people to discuss and decide whether or not we should use them, and if so, which marginal livers we should use. And I think that I was speaking to Colin Green from Norfolk Park about the question of whether or not I'm going to put any research aspects into this talk. I promise not, but I think there is an issue of whether or not you can make these marginal livers better, and I'll briefly mention how you might do that. So why are we so preoccupied by marginal livers? Well, everybody in this room will probably know that the main reason is the number of people waiting for transplantation is far greater than the number of transplants we perform. And in the UK, we have about 10,000 patients waiting for transplantation. We have 10% of those patients that die while waiting for an organ, and that equates to 3 deaths per day in the UK waiting for an organ. And therefore, improved organ donation is vital. The UK initiative in organ donation has improved organ donation rates. The most recent figure, I think, is about 35% increase over the last 5 years, and that we're going to hear some more about this aspect today. But the trend in transplantation for the liver in the UK is the increased use of marginal organs, and that is at considerable risk both to patients and cost for the transplant groups. And this is one illustration of our increased use of marginal livers. This is the use of donated after cardiac death donors, and you can see over the last 10 years in dark blue here the phenomenal increase in the use of DCD grafts, which I think we would all agree are very marginal organs. So lastly, can we improve these marginal grafts? Well, there's something we can't do anything about, the use of older organs, retrieving from obese patients. I don't think there is much we can do about those, although there's a bit of debate about that one. We certainly can do something about modulating the damage to the liver between retrieval and implantation, and our current research programme centres mainly around these 4 topics, trying to condition the organ during its period from retrieval and implantation, the use of drugs to reduce the damage to the liver, the use of machine perfusion to reduce the graft damage during the preservation period, and then trying to condition the recipient once the organ's been implanted. And these are the 2 main issues or practical approaches towards machine perfusion. This is the machine that we've been using to work on discarded human organs to optimise them, and this is the new system that's just undergone preliminary evaluation from the group from Oxford. The difference is that this machine was designed originally to perfuse with cold preservation solution, and this one has been designed to work at normal thermia, at normal body temperature. There is already significant data on the use of cold perfusion, and a first-in-man study now 3 years back, which showed that it can be done without damaging the livers, and that it may have some clinical benefit to the recipients. There's no data as yet on the warm perfusion systems. but ultimately they will come into practice, and we will have to decide which of these two alternatives is feasible and produces the best outcomes. So I hope that that's given a wee bit of an inkling as to what we're going to touch on today, the different issues. We are hopefully going to have as interactive a session today as possible. This is not meant to be a lecture course, this is meant to be discussion and interaction. So, Linda, are you going to interact? Or so we're going to have some interaction. We were going to have a system for interaction and voting. I'm not sure whether or not that's going to work. Amir says it's not going to work, so we're probably going to have traditional verbal communication rather than a keypad. And I hope you all enjoy the meeting today, and I'm sure that there will be interesting discussion over the specific initiatives. Thank you very much indeed.